Start कर दें?
Yes, ma'am. Start kar.
Assalamu alaikum. Our lecture today is on rheumatic fever and its sequelae. Rheumatic fever was described in the 17th century as different components. The rheumatic fever syndrome came separately, the chorea came separately, the symptoms and the valve abnormalities, the joint pain, they were all described separately, and it was very late that they were put together as rheumatic fever. It's a very ancient disease, but still continues to be a disease in unprivileged countries. The incidence and prevalence in Pakistan did not decline until recently. There's a slight decrease in the incidence and prevalence. It is 1 to 3% of hospital admissions, and the prevalence is among school children, 10 to 11 per 1,000 school children. And the culprit here is the beta hemolytic streptococcus, group A, and it causes pharyngitis. The pharyngitis, it is actually a bacterial pharyngitis, and differs from viral pharyngitis in the sense that there is a lot of pus points and pustule and exudate in the pharynx, which is edematous red. And how it differs is you do not have runny nose and coryza in streptococcal pharyngitis. You have high fever toxicity and odynophagia or difficulty of painful swallowing. And when you open the throat, you see something like this, lot of exudates. So this is a bacterial pharyngitis. And this beta hemolytic streptococcus has been classified into several types. It's the group A that causes rheumatic fever. The ones that cause rheumatic fever, those strains are called rheumatogenic. Okay, and it is the M protein in that bacteria that is the most virulent. It produces a lot of enzymes which we use for diagnostic purposes, which will come later on. Like acetylizing O and S, we usually use this for diagnostic purposes. So the virulence is basically related to the N proteins. And for some reason, the strains in the developing countries are supposed to be more virulent than in Australia and New Zealand. There are certain host factors. In the host factors, the age limit is from 5 to 15 years. So if somebody at 3 years gets joint pains, it's very unlikely to be rheumatic fever in origin. And after 15 years, the bacteria doesn't cause so much of acute illnesses. And then the host may have a genetic susceptibility to this organism. And this may be single recessive gene mediated or HLA mediated. This HLA predisposition has been well documented in Pakistan and other developing countries. So some HLA types are prone to develop rheumatic fever. And also once you have a rheumatic fever, you have been identified as the HLA susceptible person who can have more recurrences. And secondly, you may have some altered defense mechanisms that will make you more susceptible to rheumatic fever. For example, you may have increased adherence of rheumatic fever, bug to the throat and something like that, or maybe the immune response is not up to date. Malnutrition may be predisposing to this condition also, because we have a lot of malnutrition in our country. And then you have certain environmental factors that are very important. The West got over the rheumatic fever even before the advent of penicillin, because they took care of the environmental factors. They took care of their overcrowding at home and school. They improved their health facility. So our problem still lies with poverty, overcrowding at home and school, lack of healthcare facilities, and lack of awareness amongst doctors and teachers. This I particularly want to say that even doctors are not aware that this streptococcal pharyngitis has to be treated for 10 days. So what a lot of antibiotics are given, and very willingly the parents also take the antibiotic, but they are prescribed only for 5 days. So 5 days treatment does not eradicate a streptococcal from the pharynx. So you can still have rheumatic fever if you don't give a 10-day course of penicillins. So the overcrowding is one of the major important factors in our setup, I think, because we have very small classrooms and they are jam-packed with students. This is a hypothetical bacterium that has several layers in its cell wall. So you have got a capsule, you have got hyaluronic acid in the capsule, the cell wall M protein, and then inner cell wall has carbohydrate. All of these layers of the bacterial membranes are cross-reacting with body tissues. So they have got cross-reaction with joint tissue, myocardium. In the myocardium, all 3 layers of the heart, myocardium, endocardium, and pericardium. All three layers of the heart are involved. And the brain, you have got involvement of the subthalamic and caudate nucleus. So you can have disease that manifests in all these organs. And this is a cross reactant. This is this is antibody mediated reaction. So once this antigen is in the body, the antibodies are formed. It takes 3 weeks for antibodies to form, and after that, the disease starts. And the classical manifestation of this disease is an arthritis. This arthritis usually involves large joints, and it can be single, monoarticular, or polyarticular, because recent guidelines have changed the polyarticular nature in developing countries. Even if you have a single joint which is swollen and tender and has show signs of inflammation, you can put that as a criteria, major criteria for diagnosing rheumatic fever. This joint, small joints are usually spared. So if you have small joint involvement, you should think of alternative diagnosis. But large joints, they're very painful. They're not so swollen, but they're very painful, exquisite pain. So the large joints, really small joints, it's a migratory polyarthritis. Migratory, if it flits or fleets from one joint to the other, and the pain is out of proportion to swelling. The swelling doesn't look so prominent, but it is extremely painful. The child cannot walk to the bathroom. It is that painful. And however, it is self-limiting. It responds dramatically to aspirin, does not leave any sequelae. The next system to involve is the heart. In the heart, it causes pancarditis, and 75% of the manifestations related to the heart. How do you diagnose or how do you suspect pancarditis? Pancarditis, all 3 layers of the heart can be potentially involved. You have got tachycardia all the time, but during the day, tachycardia, heart rate may not be so reliable. So it's always better to take the heart rate during sleep when all anxiety factors are removed and the child is sleeping. Then that tachycardia becomes, if it is the heart rate more than 100, it is significant. Then you have got new murmurs. Some murmurs come, and the most common murmur is because of the mitral regurgitation. It's a pansystolic murmur, at least of grade 2 by 6. It is best heard at the apex and radius to the axilla. Less commonly, you can have aortic regurgitation murmurs also, like early diastolic murmur, or you can have a mid-diastolic murmur of mitral stenosis. Very importantly, you auscultate this murmur daily, you admit the child, you will find a little change in the nature of the murmur every day. The first day it may be very soft sounding, the second day it may be loud sounding, the third day it may be musical sounding. So it changes its quality every day. That also becomes a very important diagnostic parameter. So if this murmur or the regurgitation is bad or the myocardium is involved, the child goes into cardiac failure. Early manifestation of cardiac failure would be gallop rhythm. Gallop, you mean like a gallop of the horse? Triple rhythm. S1, S2, S3 with tachycardia is a gallop. Then if you are in cardiac failure, you will have pulses alternance, meaning alternate pulse will be strong and the other alternate pulse will be weak. And then congestive heart failure, overt florid will happen in very few cases. But pancarditis is the most important manifestation because it can be life-threatening. The other manifestation of Sydenham's chorea. Sydenham's chorea occurs in 15% of the patients. And Sydenham's chorea, you have got a lot of involuntary movements. So this does not occur with joint pains because it would be very, very unfair on the child that he has swollen, painful joints, and then he has involuntary movements on top of that. So this is basically a late manifestation, more commonly seen in girls. And you will not have other manifestations along with this chorea. You will not have joint pains. So this may be a little difficult to fulfill the Jones criteria when you have Sydenham's chorea. The chorea, the Sydenham's chorea, classical triad, is hypotonia, involuntary movements, and incoordination. The hypotonia can be mild, can be severe when it is called chorea paralytica. The choreiform movements are very characteristic, and they are absent in sleep. They are proximal, non-repetitive, and the range is wide. The child continues to grimace, and the symptoms are that these children are clumsy, very fidgety. They make faces. They have deteriorating school performance. So the first person to identify chorea is usually a school teacher who says that this girl or this, because it's more common the boy, is not performing, is just making, disturbing the whole class and so on and so forth. So it's usually picked up by the school teacher. But if it comes to a doctor, you must elicit a few signs which are very characteristic for chorea. Milkmaid's grip. It's like when you ask a child to hold your fingers with the hand grip keeps loosening and tightening. So it's like a milking effect. It's called milkmaid's grip. Then if you ask them to protrude your tongue, it's a darting sign. The tongue cannot stay still outside the mouth. If the child keeps pulling and putting the tongue out of the mouth. So that is called darting sign, hyperpronation sign. These are the few signs that you need to elicit to be able to say this is chorea. In coordination, is a fine in coordination. If you do a finger nose test, probably he will pass through. But if you ask him to button or unbutton a shirt, that is fine coordination, or thread a needle or a handwriting, then that is where the child will fail, he will not be able to do it. So chorea has a good prognosis because it is self-limiting and will take about 6 months to resolve on its own, or you will have sometimes need to give medications like phenobarbital or benzodiazepines and so on. If a child has a recurrent rheumatic fever, chorea will also come back again. That's one very typical feature. So the next manifestation is subcutaneous nodule. You can see this painless pea-sized nodules under the skin on bony prominences. They are mobile, painless, and they'll be found on all bony prominences. What does they represent? It represents active rheumatic fever or active disease, but it is seen only in 5% of patients. Similarly, this is called erythema marginatum, and you see rash, which has got a margin which is red and a center which is a little pale. So this is seen on the trunk. And if you have any suspicion, you can put a warm towel. This rash will become very prominent. Again, this is seen more clearly in the white skin as compared to a colored skin. This also is a sign of activity. So we have discussed five major criteria, namely arthritis, carditis, chorea, subcutaneous nodules, and erythema marginatum. So these constitute five major criteria of Duckett and Jones. Duckett-Jones criteria kept on revising. The latest revision is in 2015. You have major criteria and minor criteria, and major are the ones that I just told you, and the minor are the fever, arthralgia, raised CRP, PR interval, and so on. And then you have to have supporting evidence to say that all this disease is caused by group A beta hemorrhagic streptococcus. So you have to get an ASO titer, and that is anti-streptolysin O titer, throat swab culture to tell you whether this is streptococcus beta hemolytic group A. And then we have got certain rapid antigen testing also, just like your COVID rapid antigen testing for streptococcal pharyngitis. So based on this, you have a diagnosis, two major or one major with two minor, plus evidence of infection of streptococcus. Now echocardiography has been introduced in diagnosis of rheumatic fever. So once you have diagnosed rheumatic fever, okay, you can have a classical rheumatic fever that fulfills your Jones criteria. Sometimes you do not have a classical rheumatic fever that may not fulfill the Jones criteria. For example, you may just have isolated carditis. The parents do not recall the history of arthritis, or it may be a very silent kind of a carditis, just manifesting as shortness of breath, or there may be a carditis that presenting very late in the disease. So you can have some variation in the presentation that confuse the clinician. The clinician should be aware of this. This is the ASO titer pattern. The diagnostic difficulties are the ASO titer is positive only for 85% of cases. So once you have diagnosed rheumatic fever, you have to put the child to bed rest for 2 to 12 weeks, depending on the severity of the rheumatic fever. If it is just arthritis, 2 weeks is enough. But if it is carditis with congestive heart failure, you may have to give bed rest for 12 weeks or until the cardiac failure completely improves. And after that, there will be a gradual ambulation. So you have to treat penicillin, the throat infection with group A beta hemorrhagic streptococcus with oral penicillin or IV penicillins, and then give aspirin as an anti-inflammatory drug. This is an inflammatory disease, which is an antigen antibody mediated. So you have to give a high dose of aspirin for 4 weeks at least, or until the ESR comes to normal. Some patients you may have to skip the aspirin because of either they are vomiting or they have a very severe heart failure where you don't want to use aspirin, which is a salt, because one of the principles of managing heart failure is to reduce salt intake. So you instead of aspirin, substitute steroids for a short while for 2 weeks, and then switch back to aspirin when the cardiac failure has been controlled with treatment specifically targeted for cardiac failure. So you have to very closely monitor the heart in these patients with rheumatic fever. So if they present only with arthritis, maybe after 2 weeks they show evidence of carditis. So you have to really examine the cardiovascular system and monitor them very closely. So, how do you prevent rheumatic fever? It's a preventable disease. The West has gotten over this disease. So there are several levels of prevention. One is the primordial prevention. That means that you prevent the incidence of streptococcal, the inciting factor, which is the streptococcal infection. So how do you prevent streptococcal infections? By reducing overcrowding, educate parents and teachers as to how to pick up or diagnose this for early starting treatment. And then there may be a vaccine, which is not really, it's a dream that has not come true, that to prevent this disease. Then you have primary prevention. That means when the child has streptococcal pharyngitis, you have to diagnose it early and treat it properly. It could be good 10 days with penicillin. Do not use fancy antibiotics. Do not use expensive antibiotics, but use simple penicillin or semi-synthetic penicillin. So treat it for 10 days. Then you have secondary prevention. Secondary prevention means once you have had rheumatic fever, now what do you do? Secondary prevention basically aims at preventing recurrences. This disease is punctuated with recurrences. So this recurrences will make the disease worse with every time it recurs. So first, if the first time if there was no heart involvement, the second time there is going to be a heart involvement, at least one valve. The third time there will be not one valve, there will be two valve involvement, and so on. The recurrence is a very bad phenomenon with this disease. And you prevent these recurrences by giving 3 weekly penicillin, long-acting penicillin injections. And lastly, is tertiary prevention, in which you have to treat the complications of the disease, in which we have valve disease that needs surgical treatment. Then the sequelae, what happens to the heart? Rheumatic fever, there's a very famous saying about rheumatic fever, it licks the joints, it bites the heart. Because joints, there's no sequelae, but the heart has big sequelae. So if you have got initial mitral regurgitation, some of it may resolve if you give religious secondary prophylaxis, but majority will continue. Initial aortic regurgitation, again, some of it will resolve, but majority will continue. And then over a period of time, you develop mitral stenosis. It's very common. So the prevalence of heart disease in our part of the world is 10 to 11 per thousand. That's pretty high. The most common valvular lesion in rheumatic fever is the mitral regurgitation. There are other causes which you need to differentiate this mitral regurgitation from, and you have symptoms of basically congestive heart failure. And there are typical findings of rheumatic heart disease that with mitral regurgitation, where you have got a pansystolic murmur that is heard best in the apex and radius to the axilla. This is the echocardiography that definitely tells you or shows you demonstrates the mitral regurgitation. This yellow is the mitral regurgitation jet. This is the left ventricle which is dilated, and here was the mitral valve. If you do an X-ray of such patients, you'll have the cardiomegaly with straightening of left heart border. This is a typical mitral disease X-ray, mitral regurgitation. So complications, if you have got mitral valve disease, complications are pulmonary edema. So they can't sleep at night because they usually have some condition in the lungs. They have hemoptysis. Then they develop pulmonary vascular disease, and over a period of time, because of dilatation of left atrium, they have atrial fibrillation, systemic embolism, and infective endocarditis. So there are a lot of things, bad complications, which can kill, every one of them can kill the child. Aortic regurgitation is aortic valve is the next common valve. You have to differentiate it from other causes of aortic valve involvement, but aortic symptoms are like MR, but they are worse than MR because this is a very major valve. Yeah. So this aortic regurgitation, you have to treat with medicines. Otherwise, you have to. These are the few signs which I don't want to go into detail of aortic regurgitation. If either mitral valve or aortic valve does not improve your treatment, then you have to go for surgery. So the indications for surgery are uncontrolled cardiac failure due to either severe MR or severe AR. So both valves regurgitating, sometimes you have a combination of mitral regurgitation and aortic regurgitation, which makes the whole thing very bad. So you have to go for surgical replacement or repair of these valves. So another indication is that the child is getting easily, the New York Heart Association function class is deteriorating. If this is a very classical way of classifying the exercise tolerance of the patient. So if the child or the patient cannot walk within the house without getting tired and breathless, this is 3, class 3, and dyspnea at rest is class 4. If your cardiac size is increasing on chest X-ray more than 2 centimeters per year, or there are several echocardiographic criteria for subjecting these patients to surgery, and there are cardiac catheterization criteria also to subject them to surgery. So surgical options, what do you do? In children, we would like to have valve repairs because you don't need a prosthesis. Prosthesis is expensive, and prosthesis, whatever you put will need replacement if it is bioprosthesis. If it is metallic valve, then you need to give other problems. So to you, what you do is you just repair the valve. How do? You do a commissurotomy, or you do just calcification, you remove. So it's the repair. Essentially, the patient's native valve remains inside. But here, when you replace the valve, you either replace it with mechanical valves or with bioprosthesis. So this is a nutshell about rheumatic fever. I'm sorry I had to start a little late because the Zoom was not working from my office. I'm actually sitting in your lecture room. So that's about the end of my lecture. Thank you so much for your attention, all of you.
Thank you so much, ma'am.